Good morning, everybody, and
machine for making the femtorexis and the nucleotomy, and then I'm going to implant a magnificent extended depth of field IOL and put in the iSTENT to control the glaucoma. So this is the Z8 platform. So first we have put in all the details of the patient, and this is a mobile system, and this is the handpiece which we are going to dock onto the patient's eye now. So I'm going to put the speculum. Open. Open your eyes. See the straight. This is a two-step dock. See the ceiling one straight. Bed nodi. Kelag nodi. Down, down. Okay, suction on. So we put on the suction, and once the suction is established, then we put BSS to have the liquid interface. It's a liquid interface system. And then this is the handpiece. So the handpiece is docked on. This is like a two-stage. And you get a click, and basically we are going to start the laser now. That is the scanning which is being done. So it has an inbuilt OCT, and you can see the OCT image there. And then it delineates the cornea and the anterior and posterior surface of the lens, and then you can adjust the capsulotomy. Yes, and that is the safety which is at 500 microns for the nucleotomy from the anterior and posterior capsule. Now it's doing the scanning, and it's ready. So we are going to start the laser. The laser has started. It's doing the capsulotomy. The capsulotomy takes about 1.5 minutes, and this is followed by the lens fragmentation. So we continue the lens fragmentation. 500 microns safety from the posterior capsule. Here I am doing a 4-quadrant nucleotomy, and then it is done. The vacuum is released, and then we will shift the patient to the under the microscope to continue the procedure.
Dr. Sri, do you prefer to do the manual incision?
yeah, am I audible? Yes, I prefer to do the manual incision. It's faster, and I like to do a limbal incision. So I don't use the femto for the making the incision. So as you can see here, the patient has been shifted. Before I start the surgery, I would like to thank Mankind Pharma and Docflix. Docflix is a streaming website where you get to watch Phaco Festival, and we have a lot of people who have been logged in and watching the Phaco Festival on Docflix. Docflix is like Netflix for doctors, so it's a popular platform for educative initiatives, and we are partnered with them to relay Phaco Festival for people who cannot attend in person. So we'll proceed with the surgery. Now you can see that the femto has been done with the Z8, and this is a 78-year-old male who has both cataract and glaucoma. So we plan to remove the cataract and then put in a magnificent extended depth of field IOL, which is from IOCare, and then the iSTENT Inject W, which is which we probably the first demo in India, and I've been using this with good results. So let us start off. So I'm using the 3D system, the RTO, and with the 3D viewing, heads-up 3D viewing system, and I have all the details of the patient and the IUL and the machine parameters. I'm using the Quatera 700 from Zeiss, the Phaco machine, which Dr. Supriya has already demonstrated, and with a 650 vacuum and 90 flow rate in the Venturi mode, vacuum mode. So I make the side port with my diamond blade, stabilize the eye, and then this is a 2.8 mm incision. Put in viscoelastic, and then I'm just grasp the anterior capsule flap and remove it. That's the hydrodissection. You see the nucleus rising. Light nodi sir, look at the light. Don't look up. So the Quatera 700, this is a new tip. You can see it's a 2.8 mm incision, and this is a new tip which is more like a square tip. It's slightly bent 12 degrees, and these are some of the tips from Germany which I'm trying out for the Quatera. You can see I'm at 650 vacuum. Just I go in and then bury and separate the pieces. So this is a 5 millimeter capsulotomy done by the Z8. I'm in quad mode, so the Quatera has something known as APM, Advanced Pulse Modulation, which is excellent for removing the quadrants. You can see that it comes out in a jiffy. And you can see that the chamber is extremely stable, even at this high flow rate, and the followability is excellent. So it's done, we have removed the nucleus.
Dr. Sri, do you always cut in 4-piece with the femto?
Sometimes I don't prefer to do the nucleotomy, but in soft cataracts, then it becomes easier. Yeah, I don't like to make it into too many small pieces or cubes, because sometimes these cubes can go and then get lodged under the iris, and moreover it kind of disturbs your view of the capsulotomy. Light and Uttari, look at the light please. So that was the cortical removal. Then I do the hydro polishing where I clean all the fibers. Visco. So I'm putting visco into and opening up the capsular bag. Look at the light nodi. This is the lens, the magnificent. So it's a hydrophobic acrylic IOL with an extended depth of field, and it's supposed to give an extended depth of field of about 1.5 to 1.75 diopters, and it has got a mild tint, yellow tint, the chromophobe there, yellow chromophobe for the blue blocker. I'm just loading the lens into the cartridge. So with this lens, magnificent lens, bilateral implantation, I think most patients are able to read N8, N6, light nodi, look at the light please. So this is the injection of the lens into you don't want to use a multifocal lens in these patients with glaucoma. They are not ideal, so extended depth of field lens is a good option. This lens also has two holes in the periphery. They are supposed to kind of create a suction effect and oppose the lens to the posterior capsule and reduce the incidence of PCO. It's got a 360-degree square edge. I'm removing the viscoelastic.
Do you plan for both eyes 0 or a little bit negative for the non-dominant eye?
Pardon? We are planning to put the iSTENT now. So once I remove the viscoelastic, I will put in myocol or pilocarpine to constrict the pupil. Light, look at the light, please. Okay. So this is the myocol to constrict the pupil. Then you use sodium hyaluronate, which is hyaluron, which is 1.8%. This is also from Care Group. So I'm injecting this into the anterior chamber. Light, look at the light, please. Don't move your eyes. So you will have to, of course, the pupil has not constricted much. Try to remove the air bubbles from the anterior chamber so that it does not obstruct your view when you use the gonio lens. Then you put some viscoelastic onto the cornea. Now you have to rotate the microscope to 30 degrees angulation. Okay, and then you have to rotate the head also of the patient. That's right, sir. And look slightly to your left. Just keep looking here. Yeah. Don't move. So it's much easier with the 3D system because then you don't have to adjust the oculars and the angle. Gonio lens. So before I put on the gonio lens, I'll show you the injector for the iSTENT W. This is the injector. So it's got this accentuator where you can retract the trocar, and this is the button, the black button to inject the iSTENT. So the iSTENT is ready. Then we put on the this is the gonio lens. So then we put on the gonio lens. Don't move, sir. Relax, please. Look straight. Look to your left. Look down. Look down. नीचे देखिए. Look down. Look down, sir. नहीं तुड्डी ऊपर कीजिए. Look down. ಕೆಳಗಡೆ ನೋಡಿ ಸ್ವಲ್ಪ. ಕೆಳಗಡೆ ನೋಡಿ. ಗದ್ದ ಹಂಗೆ ಇರಲಿ ಸರ್. ಸ್ವಲ್ಪ ಕೆಳಗೆ ನೋಡಿ. ಕಣ್ಗುಡ್ಡೆ ಮಾತ್ರ ಕೆಳಗಡೆ ನೋಡಿ. ಸ್ಟ್ರೈಟ್ ನೋಡಿ. ಮೇಲ್ ನೋಡ್ಬೇಡಿ ಸರ್. ಕೆಳಗೆ ನೋಡಿ. ಲುಕ್ ಡೌನ್. ಲುಕ್ ಡೌನ್. ಸರ್ ಕೆಳಗಡೆ ನೋಡಿ ಸರ್. So can you see the trabecular meshwork there? You need to increase the magnification. Okay, so you can see it very clearly, the trabecular meshwork and the scleral spur. Male nodbedi, hangeri, churu alladisbardu. So then this is the iSTENT inject. You enter into the wound, then retract. You can increase the magnification. Then go and you see the, so you can see the, this is the iSTENT inject. You enter into the wound, then retract. You can increase the magnification. Then go and you see the, so you can see the, this is the iSTENT inject. You enter into the wound, then retract. You can increase the magnification. Then go and you see the, so you can see the, this is the iSTENT inject. You enter into the wound, then retract. You can increase the magnification. Then go and you see the trocar there. You gently indent and then press the, so I have put the iSTENT into the trabecular meshwork. You can see that. Then I release that. You can hear the click. I go about 3 clock hours away. Again, focus. That's the second one. So you can see the two iSTENTs. You can see the ooze. Can you see the ooze from the, so it's in the trabecular meshwork. Is it visible? Can you see the ooze? Okay.
Yeah, yes, Sri Ganesh, we can see the ooze.
Yeah, then you can just go in and put some viscoelastic again. Clear that so you can see the stent clearly. The two stents are in place. Okay. Those are the two stents in place now. It's just probably at the posterior aspect of the trabecular meshwork, but it's in place. So if you see the ooze, then it shows that it's in the Schlems canal. Then again you rotate the microscope to the normal view and straighten the head. Reduce the magnification and then you can remove the viscoelastic. Light nodi, sir. You can see that it comes out as a bolus. Light nodi, kanna last. We have removed the viscoelastic. Now, very important is you see the blanching sign. So what I want you to do is look at the, sorry, I'm just hydrating the main incision. This is the area where we have injected the iSTENT. So we look for the blanching sign there as I pressurize the eye. See, can you see the blanching here that occurred?
Yes,
So that's the blanching sign when you pressurize the eye. You can see that. You can see the blanching there. Again, if I release it, you can see the episcleral vessels there are more prominent now. Once I pressurize it, can you see the blanching?
Yeah, it is visible.
Very clear here. You can see the blanching here. So that shows that this is called the blanching sign. And then the other thing is you can put on the OCT and then you see the aqueous lake. Okay, can you see the aqueous lake there? The black hyperreflective on the OCT. So that is the area where, you know, there is fluid which is leaking. When you more pressurize the eye, fluid accumulates in the subconjunctival space. The leak from the episcleral vessels. This is the aqueous lake sign. So this is the trad which I have described. So if you see you can see the aqueous lake very clearly. So ooze from the Schlems canal after injecting the iSTENT W, blanching of the episcleral vessels and the aqueous lake. These are the three signs which show that your implantation is successful. I'll slightly reduce the pressure now. Okay. And that's the end of the procedure. So this is combined cataract and glaucoma mixed surgery, and the first iSTENT W being demonstrated. Thank you all very much, and if you have any questions.
Thank you very much, Sri Ganesh, for that wonderful surgery. And that is what you were telling yesterday about the Ganesh triad.
Yes, this is the triad. So if you see the three signs, then ಆಯ್ತು ಚೆನ್ನಾಗಿದೆ. Thank you. So we will have the next surgeon who is very well known, needs no introduction. Dr. Maipal Sachdev is getting ready. So if there are any questions regarding the iSTENT W or the procedure, you can.
Okay. Yeah. 65. Okay.
You can go ahead with the questions.
Period. Give me the chair here. इसको ऐसे कर लो.
Sir, just one
Patient
question.
will come
Can
like
these
this?
patients
Okay.
undergo MRI after iSTENT W?
ये
Yes, yes.
Change करवाओ.
They can undergo MRI. It is titanium. It is made of titanium, so it is not steel. So it is MRI friendly. So usually we put in two iStents in the iStent inject W, and this is adequate to reduce the pressure by about 30% from the baseline. That's what we see are approximately about 30%, and it's much easier than doing a trabeculectomy, because for a trabeculectomy again it's an invasive procedure. Here during the cataract itself it's just another 5 minutes, you can put in the stents, and we almost like have a success rate of 90% where most of the patients can do away with their glaucoma drops. And we have done over 30 iStents now, probably the largest single surgeon series, and our results have been quite gratifying.
Put this here.